I think let us start the event. We have about 25, 26 attendees with us right now. So good evening, everyone, and we extend all of you a very warm welcome. I'm Niharika, and I will be moderating this event today. The event is called From Work to Worth, Feminist Leadership in Health. This event is being hosted by the International Center for Research on Women Asia and Women in Global Health India. This event is a part of NGO CSW 70 under this year's priority theme on strengthening access to justice for all women and girls and addressing structural barriers. So as you can guess from the title of the panel and as well as the priority theme, today we will be focusing on feminist leadership in health, especially in the context of frontline women health workers. So before we begin, once again, I will request our attendees that if you like, you can introduce yourself to each other in the chat. We also invite you to keep on sharing your reflections, your questions, your experiences throughout the event. Please use the chat box as much as you want. Please interact with each other, share experiences that are similar to our speakers in the chat box. You can also keep on flagging your questions throughout, and we will take towards the end of the session where we have a separate slot planned for audience Q&A. And also we'd like to mention that this session is being recorded. And before we move on, I'll also give you a quick overview of the flow of the event today. We will begin with a short context setting, which will be followed by the panel discussion. Then we will open up for an audience Q&A for about 20 minutes, and then we will move towards the closing reflections. So to move on, to help us ground this conversation, I'm very pleased to invite Dr. Padma Deostali. Padma is the Senior Director, Research and Program at ICRW Asia. She is a renowned expert with over 25 years of experience. She's led groundbreaking research on gender, health policy, and social inclusion, and also has been a part of pioneering WHO-recognized models for responding to domestic and sexual violence and driving trans-inclusive WASH programs. Previously, in her leadership roles at 𝐤𝐴𝐻, she has also shaped policy, education, and global best practices. So, very warm welcome to you, Padma, and over to you.
Thank you, Niharika. I'm sorry about my voice, but I must say that it's my honor to be opening this conversation, a very important one. And I begin with introducing the two organizations that bring this conversation together, ICRW Asia and the Women in Global Health India. ICRW Asia advances gender equality by strengthening systems, transforming communities, and amplifying women's voices. Our initiatives on women's leadership in the health sector equip women professionals to lead with confidence, collaborate across disciplines, and embed gender transformative practices in institutions. This conversation today is rooted in our program titled Chingari or Spark, that you will learn more about from my colleague Sapna. The Women in Global Health India chapter is part of the WHGH movement, which seeks to advance gender equity in health leadership in India through dialogues, research, advocacy efforts. Currently, the WGH India comprises more than 245 members, which include nurses, midwives, doctors, public health professionals, health policy makers, researchers, and private sector health workers. The ICRW Asia and WGH India have been raising the issue of women in leadership in the health sector through rigorous research, dialogues, and capacity building. The absence of women in leadership positions is political. It is now well established that women and others who are subject to structural exclusion are present at all levels of the workforce except the top. These are driven by a mix of structural, social, organizational, and individual factors. Patriarchy being the foremost, and marriage, relocation, childbirth, and child rearing impact women as workers. The pay gap that workplace at the workplace leads to undervaluation of their economic contribution, and their jobs are the first to be sacrificed. The nature of work assigned to women is mostly gendered. The lack of structural support for the triple burden that women shoulder, which includes paid work, unpaid domestic work, and reproductive labor, further compounds the issue. Leadership traits are often associated with men, such as assertiveness, authority, decision making, while collaborative leadership styles are seen as weak, not competent enough, or lacking confidence. Lastly, there's a lack of regulatory frameworks in the context of rising privatization and informalization of the workforce. The health sector, in particular, is characterized by a dominant women workforce whose tasks and roles have historically been gendered and underpaid, informalized, and treated as extension of their natural caregiving roles. We cannot discuss women in health leadership without acknowledging that health systems are gendered and iniquitous. Prejudices and biases rooted in casteism, ableism, Islamophobia, and homophobia are prevalent across the system. There's ridicule and humiliation for trans persons and continuation of conversion and aversion therapies targeting sexual minorities. Violence in labor room, forced abortions on women with disabilities, coercion for use of contraception, continued use of two-finger test as part of rape examination, lack of standard clinical care for domestic violence survivors are common practices. The feminist health scholar Satyamala had asked in her paper way back in 1984, titled, "Is Medicine Inherently Sexist?" Today, there is compelling evidence that indeed it continues to be sexist. However, work being pioneered by 𝐸Hat, a health research institute based in Mumbai, with medical colleges in several states of India through engendering curriculum, building capacity of medical teachers, and engaging students, demonstrates that change is possible. It's not about demanding more women in leadership positions, but addressing the unequal nature of the system itself. Feminist academics and practitioners have been promoting feminist leadership, a style of leadership that enables a redistribution of power in an organization and recognizes and respects all members. It is not equivalent to simply having more women in leadership position, nor is it feminist leadership styles that is compassion and support, in contrast to masculine traits of projecting power. Rather, feminist leadership is a politically aware process that speaks to questions of power, what it is, how it is distributed, how it can be shared, and how it is used for collective good. Building individual skills, communication, negotiation, confidence of women workers is important, but not enough. There's a need to transform systems through recognition of women as workers, emphasis on the rights of women as workers, right to fair and equal wages, right to safe working conditions, right to work with dignity without any discrimination or violence, right to participation in decision making. The conversation today on moving from work to worth brings together different approaches to strengthen leadership of women health workers through capacity building, working with managers, making changes within organizations, changing narratives through media advocacy, and mobilizing women as workers. Moving from work to worth demands more than representation. It demands redistribution of resources, authority, and voice. Thank you.
Thank you so much, Padma. You've set the context so powerfully. And I think right at the beginning of this event, you've touched upon what is at the core of this event today, that this is a political issue. This is an issue of power redistribution. And also, if we are to speak about the feminist leadership of women health workers, we also need to recognize them as workers. So thank you so much for that. Before we move on, we know that there was a slight glitch at the beginning of the event. The chat box was disabled, but now the chat box has been enabled. So please use it. Also, there's a Q&A feature over here. You would be able to see it at the bottom of your screens. If you would like to flag your questions as we proceed with the event, you can also use this feature. So you're welcome to use both the chat box or the Q&A feature. And once again, our sincere apologies for having missed enabling the chat box at the beginning of the event. Now, moving on, we would like to play a short animation video by Behenbox, which they made in collaboration with ISST. It is on the realities of ASHA workers. We all know that ASHA workers are a very important part of the public health system in India. So without much further ado, I'll request my colleague Sapna to play that video for us.
हाँ सपना, हाँ, I'll be there soon. Today I'm on house visits to check on new mothers.
खाना बना दिया ना?
मम्मी, मेरा टिफिन।
सुनिए, I've milked the cow. Put the milk in the fridge, please.
आशा दीदी,
आशा बहू,
I am Seema. I'm an ASHA worker. 1 million women like me are the backbone of India's healthcare system. Over time, this name has become my entire identity. And I'm proud of it. So is my family. ASHA means hope in Hindi, a word that carries immense weight of care, trust, and dependability.
आशा दीदी, I'm in my 4th month of pregnancy. I feel dizzy and I'm vomiting a lot. When will you take me to the hospital?
Let's go on Friday. And we need to check your anemia levels also. Are you eating your greens like I told you?
Asha beta, I feel lightheaded these days. Will you give me a tablet? Didi, the baby is not breathing well. What should I do?
Let's check this little fella, huh? ASHA workers like me are entrusted with 77 tasks by the Government of India. Everything from maternal and child health, nutrition, sanitation, family planning, and immunization. I also conduct government surveys and sometimes even election duties. But it's more than just checking off tasks. It's about the little moments of care, like counseling young girls on menstrual health or having quiet conversations with women facing domestic abuse. These are invisible acts of care and empathy, and this hardly leaves me any time for leisure.
मम्मी खाना कब बनेगा? भूख लगी है।
The Government of India introduced the ASHA system in 2005 to create a more community-focused healthcare system, to make health for all a reality. I am the bridge between the community and the government.
Hello?
Hello, Asha Didi, come soon. My wife is going into labor.
Don't worry, I'm coming. Studies have shown that having an ASHA worker like me in a village boosts access to maternal health and institutional delivery by 1.6 times. I meticulously record every healthcare metric of the village every month. These numbers are crucial for the government to make healthcare policy decisions. With each passing day, the weight of our work grows heavier and the burden quietly multiplies.
अरे मुबारक हो, गुड़िया हुई है।
My salary has not come to my account yet. It has been 3 months since I got my honorarium. How will I pay my daughter's school fees? It's hard to continue doing this job without a regular salary. We get an honorarium and task-based incentives. No pension, no gratuity, and no other social security benefits. We don't even get maternity leave like other women in government. I earn just rupees 4,000. In a good month, it goes up to 8,000. And a lot of tasks are unpaid too. My work is important to the government. But me as an ASHA worker? My labor is unrecognized, underpaid, and invisible. I wonder why I'm not recognized as a full government employee and healthcare worker. Until then, I will keep doing my job with the same pride, care, and empathy.
Thank you to the Bandbox team and thank you to the ISST team for making this video. And thank you to Pallavi, who's a panelist with us today, who gave us this idea that we should play this video as a part of this event. With what Padma has said and now what this video is trying to say is, it really sets the tone and the intent of the conversation that we are about to have today. Especially the fact that ASHA workers and many other women healthcare workers who are at the front line form the backbone of public health systems all over the globe. And they are also very firmly embedded within the care economy that is a very crucial part of the global economy as well. So I would now let us start with a panel discussion today. I think our panelists are going to have some really amazing and outstanding things to say today. And let me introduce you to our panelists today. So first of all, I'd like to introduce you to Dr. Sanjana Brahmawar. She's the co-founder and director at Basic Healthcare Services. It's a community-based organization working in southern Rajasthan. She is also a pediatrician and epidemiologist. Okay, that word is quite a mouthful, so forgive me. With over 25 years of experience, she has worked extensively across public health systems, training, and community-based healthcare. She's also anchored training for doctors and auxiliary nurse midwives, and has also helped set up the National Child Health Resource Center. A very, very warm welcome to you, Sanjana, and thank you so much for agreeing to be a part of this conversation today. Next, I would like you to introduce you to Sapna Kedia. Sapna works as an Associate Director, Gender and Social Development at ICRW Asia. She leads and supports research and programs on the issues of men and masculinities, women and leadership, gender-based violence, and gender and public policy. She's also a founding member of Women in Global Health India, and has been closely involved in shaping the Chingari program that Padma mentioned earlier, which has driven the idea of this event today. A very warm welcome to you too, Sapna. And finally, I would like to introduce you to Pallavi Prasad. Pallavi is Head of Strategy and Community at Bandbox, a feminist media organization. We just saw that video that Bandbox has made. She has over a decade of experience and has been working at the intersections of gender, health, labor, and policy. And she's also building new ways of connecting journalism with movements and institutions. So currently she's driving Bandbox's Change Labs, which is its impact arm, where she is trying to build more and more partnerships with NGOs, funders, movements, research organizations, and government. So a very, very warm welcome to you, to Pallavi. So let me start with a question for all three of you. So across your work, whether it is health programs, institutions, or media, where do you see the biggest barriers to recognizing women health workers, especially them being recognized as leaders within the health system? Where do you think that the narrative, the understanding is still stuck when it comes to women health workers, when it comes to giving them recognition, value, and also encouraging them to take up leadership roles? And as you reflect on this question, it's also, I'll request you that it would be really valuable if you could reflect on this through one or two examples from your experience. So let's come to you first, Sanjana. Let's start the conversation with you.
Sure. Thanks, Niharika. That's a very important question. I would like you all to take a look at this. So it's actually not one, but multiple barriers. So in the center are the frontline women, and these can be our ASHAs, our ANMs, our women nurses as well. If we look at how the systems are responding, what is the structure? So we see that our frontline have to report to doctors. If we look at the work, the ASHAs, the ANMs, their work is in the community. It's a lot about behavior change. It's a lot about linkages. Doctors are not trained in that. Doctors are not even experienced enough, but that they are the ones who call decisions, but not our the frontline women. We could have models of shared leadership, but we are far from there. Then comes the matter that who are the supervisors? So 2-3 years ago, we did a data collation. We looked at the district level, block level officers. In Rajasthan, they are called chief medical officer, reproductive and child health officer, block medical officer. We looked at, who these people are. And 90% of them are men, even reproductive and child health officers who are dealing with women and children. So if they are the ones who are in the decision making, then it connects with the point that Padma brought up. What is the style of leadership happening? How much is their collaboration? How much is their support happening? It's very small. And then finally, it is how are they supervised? So it is so hierarchical, so much target driven. There may be a target for family planning, then a target comes up for ASHA. There is the app coming in, so they have to create ABHA IDs. And the frontline team are scurrying around, if I use that word. And we've seen this happen in meetings, the women being pulled up, they are treated almost as one wouldn't even treat a child. They are scolded. And we've seen so many of them break down also for this reason. Looking at the community, there is one narrative that the community is very supportive, but we also see that if there is a problem, for example, after immunization, if the child has, any side effect, after tubectomy, if the woman has a side effect, it's left to the ASHA and ANM to deal with it. The community also questions them. The community doesn't see there that they are part of a system. So that is one. We've heard our nurses say that, for a task that a woman nurse does and a male nurse does, the male nurse is accepted fully. But the woman nurse is so much questioned, also a bit pushed. She's not doing enough. She's doing things very slow, whereas she could be working in a very, very similar way to how a male nurse is. So even from the community level, there are these differential lenses. And where is the empathy to see that the woman is, there is holding so many responsibilities, which brings me to my last point, that even the women themselves, there is this huge task sitting on their heads. They are the caregivers at home. They are the ones cooking. They are the ones who are teaching children. In a meeting recently, one of our nurses shared that when she asked her husband to help her with washing clothes, immediately he came back. That's your job. Why else have I brought you? So with all this, if they have farms, they are also working out there. In all of this, I think they are able to just manage one day after another. They have little time also to think over their own leadership. There's also little time for any sisterhood to develop between the ASHAs and ANMs as well. Rather, there is some constriction happening there as well. This judgment lens, this criticism also spills over. So I think that is the reality that we see here in our work. And I'll stop here.
You're on mute, Niharika.
Thank you. Thank you. So sorry, Sapna. But thank you so much, Sanjana. And I think that slide that you just shared was very, very important and also very powerful, because very clearly it showed that uh, at a community level, in day-to-day work that these women health workers do, there are three levels of barriers that they constantly deal with. One is at the level of the system, one is at the level of their own communities, and one is also within families. Something that even Padma very clearly mentioned when she spoke earlier. Maybe Sanjana, I would probably come back to you a little later, but maybe Sapna, you can come in now, and from your experience of having worked with women health workers, and now that we've also run the Chingari program, where do you see the kind of barriers that women health workers are facing?
Thank you. Thank you so much, Niharika. I must say that it's very heartening to see a lot of Chingari fellows in the audience. I think uh, Sanjana has given a full holistic view, right, in terms of the health system, their personal lives in the community. But during Chingari, one thing, and even the Swasth Ka Safar Fellowship that Basic Healthcare Services is running, uh, you know, the biggest barrier that we see is that these institutions or systems of oppression that we see around in the lives of women, it's almost like these health workers live this oppression as very, very normal, right? There is this, um, I don't want to say acceptance, but there is almost this feeling that, okay, oppression is very normal. And then that sense of normalcy, either uh, oppression due to patriarchy, or oppression due to caste, or oppression due to class, or other kinds of marginalization, it seems so normalized that our health workers, especially women health workers, they move from one end of the spectrum to other. One end of the spectrum is constantly feeling that, we've had so much pareshani, we've had so much difficulties, yet we are here, right? So that is one thing, that, we are here and we faced so many difficulties. The other part is that, look, as nurses, we are doing such good job. Like, we are here to save people. We are here to save lives, right? So there is this strange movement where it's almost like the patriarchy, the oppression has made them see themselves as almost invisible, right? And very often, um, in conversations or in programs like Chingari and Swasth Ka Safar and other feminist leadership programs, the starting point then becomes breaking this normalization. I think so. The biggest barrier is the normalization of oppression, in my opinion, Niharika.
Okay. So thank you, Sapna. Thank you so much for that. I do have a follow-up question for you, but I think I'll come back to it a little later. Maybe first, let's also hear from Pallavi, because we also know that ASHA workers in India have been holding a very strong movement for a very long time, as we saw in the video just a little while ago. And Ben Box has consistently been reporting on ASHA workers' movements in the country. So, Pallavi, how are you looking at the kind of barriers that women health workers are facing in India currently, especially the kind of reporting that Ben Box has been doing on the issue? You've been doing it for a while. You've been very consistent at it. So, over to you, Pallavi.
Yeah, thank you so much. Um, like you said, Niharika, we've been consistently, I think over the last several years, we've built what is probably the most sustained body of journalism on India's ASHA workers, Behan Box. We've reported on their labor, their organizing, their everyday lives, and we're now building a feminist historiography, an archive with a certain methodology to it of ASHA work. So the barriers that I am going to speak about are at a systems level, because that's what our reporting focuses on. It's always a structural analysis of what are the barriers that these women are facing. And they come from this body of work and these sustained relationships that we have built with the ASHA community. And the single biggest barrier is that the work itself is structured to be invisible, as Sapna also touched upon. So ASHA, many of us know, ASHA workers are classified as volunteers, but classified as volunteers and they're receiving incentives. So they are not employees earning wages. So at Behenbox, we make sure to not frame it as a question of resources or a budget constraint, which seems to be the media narrative whenever ASHA workers go on strike. Our argument is that this is a design choice. This informality is a design choice that makes leadership recognition structurally impossible. And how it connects to this panel is simply that you cannot be a leader within a system that does not even acknowledge that you're working in it. So concretely, what this informality does is, of course, it suppresses wages, it eliminates protections. You have no leave, no insurance, no grievance mechanism. But more importantly, it removes ASHAs from the institutional hierarchy. So an ASHA doesn't work within the health system. She reports to it from outside. And because she sits outside, her labor gets absorbed and credited elsewhere. Niharika, you asked for some examples. So I did go through our body of work to cull out some anecdotes, which we really consider just narrative evidence with much more weight than anecdotes are usually treated. 𝐸𝐿𝐴𝐻𝐿, an ASHA worker from Madhya Pradesh, who we worked with for quite some time, told this to us during the pandemic, that none of the reports that ASHAs collect are signed by them. They are forwarded as reports of the ANMs. So when any audit is conducted, ASHA workers are invisible. That is not a gap. That is, we propose the system is working as designed. This informality also does something more insidious, where their work mandate keeps expanding, as we saw in the animation, but their status never changes, right? So they started in 2005 with largely two main responsibilities on paper: immunization and institutional deliveries. 20 years later, they do everything from pandemic surveillance, election duty, data collection. I remember interviewing an ASHA worker during the pandemic, and she was telling me that she was asked to count the number of cows in her village. So really, the scope of tasks is just tripling in scope, but the compensation and status has not moved, because the volunteer classification means that there is no renegotiation mechanism. There is no contract, there is no job description that triggers a pay review when responsibilities change, all the things that you expect from a job. So the system treats ASHAs as infinitely expendable labor, and informality is what makes that expansion free. And this extends beyond ASHAs. Like, our work is on ASHAs, but across community health, midwives, ANMs, Anganwadi workers, the closer the worker is to the community, it seems that it's more likely that she is to be a woman, and the less likely that her labor is classified as employment. And one quick note I want to seed into this conversation is that the deeper barrier from a narrative point of view seems to be the story that the system tells about why women do this work. You know, the state frames ASHA work as seva, service, women caring for their own communities. And the kinship language that the community uses reinforces it. You know, they're called ASHA didis, bahus, behens. This naturalizes obligation and makes care work feels like domestic duty, which is in India invisible and unpaid and expected. But the nuance that this framing, the nuance here is that the state didn't invent the seva motivation. It almost captured it. Like Sapna also said, many ASHA workers joined because they genuinely wanted to serve their communities. An ASHA worker from Kolhapur in Maharashtra told us that it was not a lot of money, but I joined because I wanted to do social service and help the community. Many have told us that though it's an extremely tough job with none of the perks of the job, what they enjoy is the dignity and the sense of satisfaction that they get. So that impulse is real. What has happened is that we have built an entire labor architecture on top of this impulse. Women's genuine desire to serve has become the foundation of a system that is extracting their labor. And that is why the narrative is stuck. I want to also share a quote from Shashi Yadav, who was, when we spoke, was the president of the Asha Union in Bihar. She put it really well. She said that since women already take care of their households, the state assumes that care should extend to the communities for free. And that really encapsulate where I think the barrier is stuck. Informality as it's almost like designed invisibility. So when we talk about leadership, capacity building, etc., we must also push and prod the system to see how much is it even willing to accommodate, to be very honest, the leadership that already exists and thrives among these frontline community workers. As I understand, the work of Chingari was also to reframe what it means to do feminist capacity building, as opposed to just upskilling with tools and workshops. Are they able to develop a political understanding of their lives and livelihoods and then act on it? So I really feel that this invisibility and informality is structural in nature, and that must remain a core barrier that we all work to dismantle.
Thank you so much, Pallavi. I think you spoke excellently, and again, really hit it with what Padma started at the beginning, that this is a structural issue. And like you said, that the labor architecture is built and designed in a manner where a lot of the care labor that women in general do, it's of course a very big part of the health system, but even the larger economy, the larger labor architecture is also designed in a manner where women's labor, especially the care labor that they do, is designed to be kept invisible and designed to be kept undervalued. I have a small follow-up question, and all three of you can take turns to respond to it, but I'd request you to keep your responses within 30 to 40 seconds so that we can move to the next round of the panel discussion as well. We know this from various reports. We also know this from the reporting that Behan Box has been doing, that a lot of the women frontline health workers are also Dalits. And we also know from Chingari's experience, because some of our participants were also Muslims who were either in frontline roles, or they might also be doctors. And in that sense, women workers, their problems are not just problems of gender. Very often their problems are also problems related to caste and religion, which also Padma spoke about right at the beginning when she mentioned Islamophobia and ableism and homophobia that is present within the health systems. So I just very quickly wanted to come to all three of you, and I wanted to ask you that in your work, where have you noted this, and in terms of barriers, especially the kind of violence women health workers face in their workplaces, or as we've increasingly come to use this term, the world of work, which is where you understand the idea of workplace more expansively. How do you see this intersectionality playing out? And again, the request is that if you can keep your responses within 30 to 40 seconds, that would be really great. So any one of you can step in or come in over here.
Sure. Maybe I'll go first. So I think that's a very important point, Niharika. We see it play out, wherever there is this, the castes are different, it shows up. For example, if even among nurses, there are some from the higher caste and some from the tribal. So most of our nurses are tribals, but wherever there is a difference, then it shows up. On the ground, it shows up. If the Asha is from a higher caste, she may not also make enough home visits to tribal communities. That also happens. But I'll just stop here.
Okay. So Sanjana, what you're trying to say is that because there are caste hierarchies, this is not just a gender division of labor, there is a caste-based division of labor, and even within the women health workers, this caste-based division of labor plays out in the ways they do, the kind of jobs that they do in the community. Okay. Pallavi, I've seen you've unmuted yourself. So over to you.
I think caste is foundational to how ASHA work is structured and experienced. We found in our reporting. Our reporting has shown that from the beginning, from 2005, the cadre was disproportionately drawn from Dalit and Adivasi communities. Upper caste families didn't push their women into work that was seen as a day's work associated with marginalized castes. So caste has always determined who entered, and then it determines how they are treated, as Dr. Sanjana has said. In fact, Lakshmi ji, the Asha that I referred to earlier, this has described to us how Dalit Ashas in her area couldn't enter upper caste homes. Families wouldn't let them inside. They made them sit at the doorstep, drink water from, other utensils, etc. And during COVID, we documented how violence against Dalit Ashas in states like Haryana was explicitly caste violence. The Haryana Asha Union's General Secretary, in fact, told us that attacks on Dalit Ashas came from landed community strongmen asserting caste supremacy. So the barriers that I was describing earlier, also informality, seva, invisible labor, like you mentioned, Niharika, they don't operate the same way for all Ashas. A Dalit Asha in a dominant caste village navigates gender and caste in every home visit that she makes. And the system doesn't see even this, duplication or doubling of invisible labor.
I mean, thank you so much for saying that, Pallavi, because when you spoke, I remembered Bhavari Devi. The history of women health workers demanding their rights and safety and protection in the workplace. That struggle is in so many ways owed to Bhavari Devi, who herself was in many ways a Dalit community health worker who was also working for a government program in Rajasthan. So it's very I'm very grateful to you for having mentioned that, because what we are speaking about today also has a history to it, and this history is also very much closely linked to the struggles and the fights that women workers in India have been waging since pre-independence era, probably, and also very closely linked to many labor rights and caste, the Dalit movements that we also have in the country. Sapna, I also wanted to quickly come to you. Would you like to add something over here?
Yeah, Niharika, we're talking about gender, we're talking about caste. I think in the case of health workers, what happens is the remoteness of their work, the location, right, where they are, that also completely plays a role in sort of, making them invisible. Very recently, when we were doing the Swastika Safar inauguration, and even during the Chingari Fellowship, when these women health workers traveled from across the country and came to Delhi, just the fact that there are no opportunities for these women who are working in the most rural parts of the country, and to get them for a fellowship program, the kind of labor and effort that goes into just convincing everybody for the resources, just convincing their organizations, convincing them, and the kind of labor that they put in convincing their families, the fact that they operate in such remote locations. I think we never ever talk about, we say it in passing, ASHA workers travel, climb mountains to go and give vaccination. ASHA workers have to walk a lot. But their daily work is in the most remotest of parts. They are addressing snake bites, they are addressing high risk pregnancies, they are getting dismissed by community workers. Their realities are so far away from the symbolism that we see around health workers, from the whole thing that happened in COVID around praising and really really sort of saying that wow, they are so great, but the fact is that they are so remote that their barriers don't even cross our minds. So I think that intersectionality of location, in addition to caste, in addition to the hierarchy in the health system, in addition to gender, is very, very important. And I think tied to that is language. And we'll speak a little bit more about that. But today, because we're speaking about feminist leadership, we've constantly, as a feminist working on this issue, we've constantly had to ask ourselves this question: what is the language of feminism? And that is very, very crucial.
So thank you so much for that, Sapna, because I think what you just spoke about directly brings us to the next part of our panel discussion, especially the thing that you spoke about, symbolism. And when it comes to the leadership of these women health workers, like you said, that it cannot merely be symbolic, कि हमने उनके लिए थाली बजा दी. But as all of you have been speaking about, that it has to be very concretely rooted in their material realities. And also, thank you so much, Sapna, for pointing out the fact that along with the intersections of caste and religion, there are also these rural and urban realities, in the sense that in rural areas, the women health workers, their realities are structured in a certain manner, and in urban areas, they're structured in a certain manner. And of course, there is also the issue of language, which is, I think, something that we all struggle with when it comes to feminist leadership, especially capacity building, because there's also this pressure of having to know English and having to know a certain vocabulary, which sort of makes you look like a leader. So I think, Sapna, I will come back to you again now. With the next round of questions. And I would really request you that, since you spoke about feminist leadership and the vocabulary of feminism, can you tell us a bit more about the Chingari program? Padma spoke about it very briefly at the beginning of the event. And what did you seek to do in the Chingari program, especially in terms of the barriers that we've been speaking about so far? How did Chingari program seek to address those barriers in the way it tried to address and build feminist leadership? And if you can also take some time to also speak about those moments where participants, the fellows, the Chingari fellows themselves, redefined what leadership meant to them. So back to you, Sapna.
Thank you. Thank you so much. I think, like Padma said right in the beginning, Chingari really meant spark. And initially, when we were keeping the name of the program, we were a little cautious because, anyways, women are accused of um, putting little fires everywhere and sometimes big, right? कि आग लगा देते. So I think our spirit was that we wanted to create sparks, we wanted to create a fire, but we also were very, very conscious that we want it to be very, very accessible, right? It has to be very political, but it has to be very, very accessible, because very often the language of feminism or the way that we do politics can become alienating, right? So with that sort of sense that we want sparks, we want to be political, but we want to be cautious. That's how we started Chingari. Then the other thing was that, when you have a capacity building program, you have 6 months. You want to do sessions in person, online. You want to move from point A to point B. You want to talk about gender. You want to talk about power. You want to talk about all the oppressive things that we are talking about. And you want your participants to understand that they are part of a structure, of a system, right? And you want them to leave the program with that understanding. So what we realized as we did Chingari is that it's a completely uneven process. It doesn't work like you go from point A to B, right? It doesn't work that you give skills right? It's not about negotiation sikha diya or conflict management sikha diya, or that you've been able to explain gender, power, patriarchy, and that intersectionality, and everything will get fixed, right? Because we talk about capacity building like that. How do we look at capacity building of healthcare workers? We look at capacity building of healthcare workers largely as technical. कि technical चीजें आनी चाहिए. They should know technical stuff. And we as feminists think that they should have understanding of power relations, power, and they should be able to, navigate all of that. But Chingari, we did all of this, but our core was the development of a critical consciousness. So understand gender, understand power, understand patriarchy, but not through what we are telling you, but through what's happening in the room. So I think one of the biggest things in Chingari was that the room had almost 50 women, and they were from across India. They were from different castes, religions, language. It was so difficult to have a mix of people who speak different languages, right? But a lot of this consciousness that I'm talking about, Niharika and colleagues, happened in the room, right? We saw a lot of the patriarchy playing out in the room. We saw a lot of the casteism. We saw a lot of the, city mein we live. We can speak this language. We saw a lot of that in the room as well. Then the facilitators, who were the facilitators of the program? The facilitators, we tried to keep the facilitators diverse. We tried to keep facilitators who can speak very well in Hindi. We tried to keep facilitators who've never done facilitation before. We tried to have a team member who doesn't even know feminism, right? So many of these things. And that, having a team of facilitators that didn't speak like us, really helped us develop a program that was very, very real, right? And I think that was another aspect of Chingari. Uh, we realized that when we talk about leadership, capacity building, it's not a magic wand. It is largely about holding space. Are we all committed to holding that space? Are we all committed to having conversations, right? And when we ask the question, what is the impact of a program like Chingari? What are we measuring? That becomes very, very important. Are we measuring, like, at the beginning of this conversation, Niharika, you were telling Pallavi that we used Behan box stories in our training in Chingari. And Pallavi said, oh, we never document this impact, right? So feminist leadership programs that talk about critical consciousness, that hold space, how are we looking at impact? Impact has been for us to have women who are 18 to 20 to 22 years old share space with women who are 50 to 52 years old, and then debate with each other. Say that these are our issues. The elder women say these are our issues. And then later they say that, oh, I don't agree, but I'll listen to you, right? It has also meant that sometimes we've been called out as facilitators that you keep saying inclusion, inclusion, but inclusion is not a gesture, right? Inclusion is work, right? I remember within the facilitator team, we had almost a big disagreement once that, we cannot be doing inclusion that, okay, you have 56 participants or 50 participants, and out of that 10 will be from here, 10 will be from there, 10, and that is representative. It is beyond that. So I think that was very important. And one more thing, we spoke about a lot of this power and all of that, but in after 12 sessions, at the eighth or ninth session also somebody would come and say very problematic things, right? Then what do you do? What do you do? Do you give up and do you say, ki, nahin, we shouldn't be doing this work, right? So there is so much discomfort in the process of feminist leadership building within the women who participate, but also amongst facilitators, right? So much discomfort. Yet at the same time, what is happening is a lot of churning. There is a lot of, sort of space holding. And I think we don't value that enough. I think that we are used to thinking that we have this illusion of certainty. I'm using a philosophical term, but we almost have that, we do something, we work on gender, we work on feminist leadership, and there is this end goal. There is this certainty that these 46 or 50 women, out of which maybe 35 women will come at the end becoming feminists. It's not that. It is a lot of development of critical consciousness back and forth. So I would say that it's really about space holding, and I would say that it doesn't look the same everywhere. So I think that is very, very important. And um, before I hand it back to you, I really, really want to acknowledge the whole Chingari fellows, the fact that they bought all their realities, and the fact that we could create a space where a lot of the space holding could happen. I really, really appreciate the debates that the facilitators did, and all the team is here, Niharika, you, Birja, Shruti, Vanya, and Deepika. So I feel like a lot of what I just said was learning that happened in the course of the program. So feminist leadership programs develop as they go along. It develops based on the facilitators. It develops based on who's in the room. I'll stop here.
Thank you so much, Sapna. That was like a trip down the memory lane because, the capacity building happened last year, but we're still in the process of putting together our knowledge products for Chingari, and so much of it came back to me in terms of what we did in the program. And I think, Sapna, there's one very critical point that you also mentioned, uh, that whole point about critical consciousness or critical thinking, which is often seen as, often capacity building programs, especially leadership programs, are divided into these two parts. Or we are going to build perspectives and we're going to build skills, uh, as if the two have nothing to do with each other. But also at the same time, critical consciousness or critical thinking, the ability to do that in itself is also a big skill. It's not just a matter of perspective, and that is also something that's cultivated through a lot of practice and having to do it again and again. It's not like once you do it and it's there and that's about it. You have to also keep on practicing critical thinking. So that's a very important point that you made right over there, Sapna. With that, I want to actually now come to Sanjana, because like Sapna just said that it's of course in capacity building programs we do tend to focus on individuals, but at the same time the idea is that we understand something that is very structural in nature and not just limited to building skills at a very individual level. So Sanjana, over there, I now want to ask you that even though still a lot of the leadership conversation tends to focus on individuals, what about institutions? They often still remain unchanged. In your experience, what are the shifts that are needed within institutions, health systems, organizations, so that they are able to sustain and nurture feminist leadership among women health workers? And it would be really valuable if you also speak about how you've been doing it at BHS. There are a couple of references we've already made to the nurse leadership program, but I know that there are also other aspects through which you've been looking at this. So over to you, Sanjana.
Sure. Thank you, Niharika, and thank you, Sapna, for setting stage for me to answer this. I would like to just share from my presentation and start with these these two photos which tell some story. Yeah. So, and these later I'll come to what are some things that we are doing and some things that we are still learning we need to do. So on left is one of our health workers. She's also a Chingari fellow. Sapna will know. So, and you can see her absolute abandonment here because she's just learned riding a two-wheeler. So this is also something that we nudge, we push, we encourage our team members. So till now, there were hardly any of our, frontline women who were riding a two-wheeler. But now you will see 3 or 4 of them whizzing around. Geeta is the first one who did that. On the right is a group of us, importantly, a group of our nurses who went to a conference in Wardha. And again, this is the first time they were traveling. They went there, they presented before packed audiences. And this is something that made them so happy and proud. The next slide, please. So very early, when BHS began 13 years ago, we knew that training and hand-holding, preparing job aids for our frontline women would need to be an important part. And we've been doing this. We've also seen the change that happens. So when nurses, they learn protocols, they are able to diagnose malaria, diagnose even severe malaria and treat it, or a case of complicated delivery. So one of our nurses, she managed a delivery where the head had come out, rest of the baby was stuck. A senior gynecologist said, you can't do anything. Please pack the woman, the vagina and refer her. But the woman says, I'm not going anywhere. So for almost an hour, the nurse managed the situation. She was on a video call with a senior and she conducted the delivery and both the mother and baby were fine. So the boost that it gave, I think that's, we can all understand the on-job support that the nurses have. So many of our nurses have come back and shared, even to external people that they really value that if they call a doctor, even at 2 a.m., they know that the call will be answered. I think this helps. Then having feedback mechanisms of, anything feedback to be done in private, the praise to be shared before all, but any specific feedback to be done separately, taking care of the accommodation. We have a practice of all of us sitting and having the meals together. Frankly, we didn't think too much of it, but in interviews, they have said how much they value this. And they say, we all eat ek saath. Iska matlab hum sab barabar hain. So these are things which have been there from the beginning, but we've learned more over time. We've learned it's important to really recognize and appreciate the good work that happens. It's not enough to just keep it inside us. So whenever, life is saved, a difficult patient is managed, we share it out in the WhatsApp group, we acknowledge, appreciate them. Sometimes if we stop this, we get feelers. Why is it that you all are not appreciating, or is it that maybe you are appreciating nurses from one clinic more, but not talking about us? So this is something that goes on. Also sharing their stories. So on Women's Day, we've been doing stories of our nurses, health workers, our daycare center workers. And we are told that when the stories reach their families, the families are also so moved. They tell so our nurse shared this recently, that my father was almost in tears. He said, "Mujhe nahi pata tha tum itna kaam karti ho." But then going forward, I think that is something that we need to do even more. We've learned this more over time, that how important a role the families play. The families many a times are controlling, whether the nurse or the health worker works or not. How is the money she is earning being spent? We also realize that the families don't know enough of the huge value of the work the women do. So a need to connect back to them, to both appreciate them, but also to let them see the power of the work. So in fact, as we speak, we've just done a Women's Day celebration where we invited the family members to also come and be a part of it. But we need to do more of this. Another is building their leadership. So we've spoken about Swastika Safar, which is our fellowship for rural nurses, not only nurses from BHS, but from other places as well, from several parts of North India. And even this is letting us unpack some of the things that we had thought. We see that in the inaugural that happened last month, the way the nurses came forward and really embraced each other. We were not prepared, we still had the more urban mindset, but maybe there is something different. So they really opened up. They were very candid with each other. They made bonds. They laughed with each other. But we are just learning. And I really like the point that Sapna made. We develop as we go along. This is just the beginning. And final point is, how do we create even more gender sensitive systems? We realize that we need to have a differential approach for a woman patient with TB, because her challenges are going to be much more different and difficult as compared to that of a man. And we are seeing small shifts happen. So, and again, this connects with Chingari fellows as well. Sapna knows this, that the narrative is shifting. So earlier, the narrative might have been कि अरे वो एक हाई रिस्क प्रेगनेंसी फॉर एग्जांपल कि नहीं मैम वो तो इलाज लेना ही नहीं चाहती, बट इट इज शिफ्टिंग टू सेइंग कि मैम उसकी फैमिली उसको सपोर्ट नहीं करती. But this also connects with the point. So these are all agendas for us to keep working on. What I also want to say is that this work is also, it never ends. You know, you keep learning of what more needs to be done. You keep improvising. You keep building connections with others who add to it. And just the last slide, please. Yeah, so this is a Women's Day celebration that we did 3 years ago on the right. And these were government nurses. And a very senior nurse, she whispered in my ear, ki, ma'am, aisa kabhi nahi hua mere saath. They were thrilled at it. And on left is a poem that one of the nurses, she wrote and she read out. I think this really moved us all, where she says that my work is my worship. Ye nahi hai meri lachari. और मैं ही अपनी कर्मचारी हूं और मैं ही अपनी अधिकारी. एंड शी सेज दैट जो मुझे सम्मान और प्रतिष्ठा मिला है मैं इसकी हूं सबकी आभारी.
Thank you so much, Sanjana. I love that line. मैं खुद की ही अधिकारी. That's a very, very powerful line. And I mean, I'm so glad that you put up that poem on the slide. But also, Sanjana, I think very importantly, what you also said is that we can have this intention of wanting to support them, enable them, empower them, but that intention has to be very consciously translated into very concrete actions inside institutions for them to be able to really nurture and sustain the leadership of women health workers. And I think both Sapna and you've been speaking about making a space, holding a space, and there's also a question in the chat box about it, but I'll come to that later. I want to now again come back to Pallavi. And Pallavi, we've already spoken about the kind of reportage that Benbox has done on ASHA workers. But I would really request you to also now talk about how have you done it. I mean, we can see the reports and we've all been referring to them, using them, but as a feminist media organization, how have you done it? And like you said earlier, Pallavi, that there is also this very limiting, dominant discourse about women health workers in the country. You know, unko seva ke nazar se dekha jata hai, that they're giving seva. So now, as a feminist media organization, what is it that you've done? And also what kind of partnerships and collaborations that you've built to challenge this dominant narrative and to build a more feminist narrative of around women health workers? So over to you, Pallavi.
Sure. So the language of seva and the informality is the dominant discourse that permeates policy, it permeates law, it permeates media across. The media specifically, which is what I want to talk about in this question, it has its own version of the stuckness. So take ASHAs. When ASHAs appear in mainstream coverage, it's either crisis, so unpaid, attacked, overwhelmed, or it's celebration, backbone, foot soldiers, heroes, climbing mountains, like Sapna said. Sustained, consistent, rigorous, nuanced, meaningful feminist attention is utterly rare. They figure only in legacy media when they either protest or strike. Both these, celebration and treating them as, crisis or celebration, both these modes make the worker an object. They are either a victim or a hero. They're never someone who produces knowledge. They are never someone whose expertise is evidence. So I think in preparation for this call, we were having a chat, all of the panelists, and as it often happens, Sapna articulated what Behenbox is doing better than Behenbox has managed when it comes to ASHA reporting, that our shift has really been from a rights violation frame to a social justice narrative. And what does that mean? It means that we are saying that these women aren't just owed something, which is the rights violation frame. The social justice narrative is that these women are building something. They are building community health infrastructure. They are building epidemiological knowledge from the ground. They are building care systems that hold entire communities together. And the system is extracting that building while refusing to call it work. So that is the narrative shift that Behenbox has worked on. I'll give you an example. Minnie, who is an ASHA worker from Kerala, told us, I hope the world sees more of what we ASHA workers are doing and what we can do. What we can do. That's the narrative shift in one sentence. And that reframe changes everything editorially that we do as a feminist media organization. For example, it changes who you interview and how. So the frame changes from not tell me about your hardships, but tell me what you know about this system. Workers as public intellectuals, as knowledge holders of the work that they do. It changes what counts as a story. So it's not just the crisis, but it is the everyday texture of their labor. We've done reporting on the ASHA workers' sari that has become a symbol of solidarity. We've done reporting on the caste dynamics, like I said, of how the 2005 cadre of ASHAs was selected. And it also changes the relationship between the journalist and the person in the story. And this last part is the hardest and most important when you talk about media strategy, because the dominant media model will treat sources as raw material, right? You go in, you extract a quote, and you leave. Feminist media, feminist journalism, if it means anything, it has to break that extractive cycle. So quickly, like a few examples. One of our reporters, Shreya Raman, she reported from Sambhaji Nagar on the Hajri surveillance app that was introduced. It was a private attendance tracker that forced Ashas to submit photos 3 times a day. This essentially destroyed a worker named Vaishali, her ability to hold 3 side jobs that her family dependent on, right? So that reporting that we did, it directly contributed to policy concession within days. The attendance requirement reduced, days off were granted. So what I take from that, from a media strategy point of view, is that when the journalism or the storytelling is grounded in the specificity of a worker's daily reality, not just Ashas are surveilled as an abstract claim, but where Shali's life in her community, it becomes very hard for the system to dismiss. So specificity as a media strategy is something that Behenbox does. Then Minnie, who is the ASHA worker from Kerala that I mentioned, she is a former shrimp peeler, first generation learner. Instead of profiling her from outside, we asked her daughter Nimi, who is a writer and an artist, to write about her mother's life. That was an editorial choice about who holds the gaze. It places care labor inside a family so that intergenerational weight becomes visible in a way that a journalistic profile from outside can't capture. And it also makes the reader confront the fact that the cost of underpaying an Asha doesn't just stay with her. It moves through her family to her daughter. And that is a different kind of evidence that we want to put on the table when we make a collective case for Asha workers. Another example, Lakshmi ji, who an ASHA worker that I talked about, she has gone from being a source to someone who is actively shaping what our work on all things ASHA looks like. For example, last year she told us that she imagines a system where ASHA workers log their own tasks, hours, and outcomes, because when she says she works 18 hours a day, officers ask for evidence, which, as Dr. Sanjana mentioned, are mostly men. They ask for evidence, and Lakshmi ji said there is none, except, in her own words, our blood, sweat, and tears. Right? That's not a quote for a story. For us, that is an ASHA worker articulating a design brief. And the fact that she could do that with us tells you something about what changes when you stay in a relationship with the community for a longer time. So now this insight is woven into the ASHA archive we are building. So we are calling it the ASHA story. It is a feminist historiography. It is our flagship project for this year. We are having many, many meetings on just no matter what happens, this is what we're going to build at 𝐵𝑒𝑛 Works. A historiography is essentially a claim about how the history of public health labor in India should be written and whose voice should be in it. So the feminist bit of this project is structural. Lakshmiji's audio recording of her working day will sit alongside a Supreme Court order on ASHA wages. And an ASHA worker's logbook entry will occupy the same evidentiary weight as a parliamentary committee report. So everything from photographs to first-person reflections, oral histories, policy documents, we want them in one place, and we want them not methodologically sorted into personal stories and official documents, right? We want to refuse that hierarchy and say that a worker's testimony is evidence. So this ASHA story is two things at once. It is, of course, a memorial, 20 years of women's public health labor, documented, preserved, and given the weight that it deserves. And it is a utility. A union organizer preparing for a wage negotiation can pull the evidence that she needs. A researcher studying informal health labor can access primary material that would take years to collect independently otherwise. Or a policymaker drafting a community health workers framework can find structural analysis and lived reality in one place. And most importantly, the core group that we want to build this for, ASHA workers. An ASHA worker in, say, Assam can see that what she's experiencing is shared by workers in Maharashtra and Madhya Pradesh and Kerala. And that recognition that I am not alone in this is structural, is itself a form of power. And as part of this project, we're developing tools built from the needs ASHA workers have articulated. Like I mentioned, that time use and wages documentation tool that Lakshmiji put us on, a protest tracker, a chatbot. These are initial ideas that we're toying with based on the signals we've received from the community. But the idea is, why are we doing this? We're doing this because we the first 5 years, we did the most sustained journalism on ASHA workers, right? Journalism produces evidence and public narrative. But evidence in a newsroom, in a media organization, does not reshape how a sector thinks. So this is the thought behind Change Labs that Niharika so kindly introduced in the beginning, which is our impact arm. This is where we form strategic partnerships with other players in the change ecosystem to help shape the answers to the questions that our journalism asks. So really complete the loop, not just ask and surface questions, but then help shape the answers as well. So it is how our ASHA reporting and our archive are going to enter the wider ecosystem. These partnerships can take different forms depending on what the work needs. For example, research collaborations like our 10-state study on female frontline health workers with 𝐰𝐨𝐻𝐿 University. It can look like a co-production of knowledge tools like that animation you saw, and we also did a workbook on ASHA workers with ISST. Or even research on women's leadership in health with women in global health. Other ways we want this archive and our body of work to interact with the change system is advisory and strategic input for organizations and government working on health, labor, and gender justice. So we go to them and we say, these are the patterns we are seeing on the ground because of our deep community relationships and trust. And this is how you should be thinking about program design and delivery, which you may be missing from a gender and marginality point of view. Union workers, grassroots organizations can bring evidence from this archive into their community-facing or policy-facing work. So the archives gives us the evidence base to keep entering these conversations in the ecosystem, and each partnership shapes what the archive becomes. I'll stop here by saying this. This panel has been asking what feminist leadership in health looks like. The work that ICRW and Women in Global Health are doing, and basic healthcare services, which is creating spaces where women health professionals develop beyond the superficial idea of capacity building that has taken hold of the development sector's imagination, and help them develop a political understanding of their own position, where they can name the power structures around them, as Dr. Padma referred. that matters most because most ASHA workers have never had that space that we are trying to create. But at the same time, I want to gently push back on this assumption that often comes up in conversations like these, that frontline workers need to be taught critical thinking, that they need awareness building, that they need political education. And yes, many workers haven't had that space to name what perhaps they already experienced, to name the personal as structural. But many also who already have that understanding and then analysis, they just don't have the conditions to act on it. So Lakshmi ji didn't need a workshop to know that her labor is misclassified. She told us that. And Kerala's ASHA workers who went on strike last year didn't read or like weren't in a capacity building on collective action. They sat on a picket line for 260 plus days. So the question is both. Yes, let's build the spaces for political understanding. That work 100% matters, but also recognize that for a lot of these women, the barrier is not awareness. It is that organizing costs you your livelihood when you're classified as a volunteer. So the gap is not just consciousness, it is also conditions and access, and that's the work. Building and holding those spaces like Chingari, like Swastika Safar, like Behan Box's archives, to make sure that these women get these spaces, and then that the system can't look away from what emerges when the women do have these spaces.
Thank you so much, Pallavi. I think while you were speaking, you also answered one of the questions that came in the chat box from Priya Darshini regarding this, this precedence that is given to statistics and large data over important lived stories. I think you pretty much answered that question. I also wanted to again reiterate that this whole this idea about specificity, that is also something, as a facilitator I can speak, it's something very central to the idea of feminist pedagogy as we approach capacity building, that we, as Sapna said, that we start with lived experiences, that the starting point of all knowledge building is lived experience, and where we also try to shake these hierarchies of, as you said, of who holds knowledge or who holds wisdom. So we've run out of time. We wish we had some more time to take up a few more audience questions. There is one question that Nandini has put up regarding the loss of collective spaces and organizing, and Pallavi also just mentioned that. That the organization, when women workers organize, that may mean that they may face a lot of resistance. They may there's a huge cost attached to that. So the whole idea of building collective spaces is also a very structural issue, where we know that collectivization of women workers entails a certain entails resistance, entails even further invisibility. But since we have run out of time, I would request that if any of the panelists or speakers would like to take up that question, they can address it in the chat box. And with that, I want to move towards the closing of the event today. And I want to invite Dr. Kaveri Myra to bring us to the close of this event. Kaveri is the chair of Women and Global Health India. And she's been working at the intersections of feminist theory, decolonization, and women's health. She's also an award-winning researcher and has been featured on media, blogs, and podcasts globally. She's also been recognized as one of the 100 outstanding global midwife and nurse leaders by Women in Global Health, WHO, UNFPA, ICN, ICM, and Nursing Now. So, Kaveri, over to you.
Thank you so much. This has been such a learning experience for me. Also, my head is buzzing in different directions. I have been writing down on sticky notes and just like putting them away, because I feel like I have to get in touch with each one of you and be like, when you said, what is the language of feminist leadership? Do you want to write something about it? And there are such great quotes. So it will be a task to summarize. There's a lot of issues that continue to remain in the system, in how challenges and barriers tend to occur in women's leadership and also when it comes to frontline. There's also more language to some of these. This is a good time, I feel, for some of the action that is happening, for a collective space for feminist leadership to flourish. But before I say more on that, I want to talk a little bit about the work that I have been doing. And it sort of touches upon all the things that you have said about intersectionality, about invisibilization, about normalization of violence. So my I shouldn't say my expertise, but I do research and advocacy on obstetric violence. Please do look it up because explaining it will take some time. But basically during labor and childbirth, when someone is abused in different forms of way. Now, the most interesting part is this abuse is happening at the hand of healthcare providers. We work in a deeply rooted patriarchal structure. And we deal with a social hierarchy. We also deal with a medical hierarchy. And what is happening, the people we are talking about are people who are at the bottom of both these hierarchies. Maybe, when you think of intersectionality, some of the points that you have raised in terms of location, in terms of remoteness, religion, caste, language, marriage, age, socioeconomic status, there's so many of these that help you understand. And the level of vulnerability is sort of a little unfathomable when you actually put all the intersections, particularly in terms of India, and keeping the diversity of India in mind, because that also changes with different regions, different states, right? Now imagine that intersectionality, that vulnerability collides with the vulnerability of healthcare providers and care providers such as ASHAs. Like, how much worse can things get? That one has to think in those lines. When it comes to feminist leadership, I have, in the recent times, I have been called notoriously, famous for being feminist leadership. And there is a ring to it. There are pros to it, there are cons to it. But what I have understood is, in terms of also maybe thinking about the language of feminism, I think the idea is to cause a bit of discomfort. And I have sort of felt that actually it's being hinted that maybe a person, when they're called feminist, you are talking about people who light little fires everywhere. You're basically causing discomfort. So I think the success of an initiative as beautifully titled as Chingari is creating these spaces of comfort and compassion, like you have through this initiative, to enable people and give them the strength to go out and cause like a major level of discomfort. I don't know if it's all connecting, but there is a strategy that I would like to talk about it. There is something about amplification, and to explain that, I want to talk about road construction. There are vendors who get these road constructions, and they will, the composition of what you're putting in that cement roller thing is very strategic because you want to get the vendor next year. So I think when we get these efforts of funding, of knowledge, of people who are actually supporting, is very much to a level where we are able to amplify, or we are able to empower frontline workers such as ASHAs, ki yahan tak to ho jaye. To a certain level, they should function, but then some level of disempowerment is very important because you want to continue to empower people. That this narrative has to go on. So yeah, a lot to think. I'm not saying I have answers to a lot of things, but there's definitely a lot of alignment in ways that I think. And I think the point of this is to have spaces, feminist spaces that you have managed to create as well. I'm very excited to see that there are a lot of fellows who I have been reading about and seeing pictures of, and then going and looking up what organization are they working with, what did they start, what did they create. And I will be going down this rabbit hole for a few days now. But please allow me to, if I can, close this event, even though I understand there will be a lot of streams of conversations, and I will be initiating a few on multiple platforms. Thank you so much, ICRW and Women in Global Health India, for bringing this initiative together, running it. And there's so much enthusiasm that I almost feel envious that I wasn't a part of it, and I'm here a little late. Thank you so much to the panelists, Sanjana Brahmawar, Pallavi Prasad, Niharika Mahajan, Padma Deosthali, and Sapna Kedia. Some really interesting conversations and questions in the chat box. Thank you so much for all the attendees who have stayed on. At some point, I saw it cross 55. Thank you so much for attending. Thank you so much for all the people who became a part of this program, this 𝐤𝐴𝐻 Fellowship. And it's just, being able to take that time for yourself and investing that and saying that I'm going to be a part of this space and meet these people every day. And we are up to something really amazing and really notorious. And we have no idea what we'll probably get up to after this, but just having that faith in yourself and just taking that time for yourself, I think that is so important. Thank you so, so much for doing that. As a new chair of Women in Global Health India, it's such a privilege to be part of this beautiful event and to be able to close this. I also want to encourage you to please join Women in Global Health India. It is not just for women, it's for people who believe in feminism, in critical theory, in voices like these, in solidarity, in support. And we are also trying to create a sort of space for compassion and comfort, and trying to create a lot of discomfort outside of it. So please do join us. Thank you so much.
Thank you so much, Kaveri. And we would also like to extend a heartfelt thank you to Anurag and Pooja, who are a part of our comms team at ICRW Asia and who have consistently supporting us in bringing this event together. And also we'd like to thank Shruti. Shruti has been a part of the Chingari team and has been actively holding the chat box and the Q&A section today. So thank you so much, Shruti, for doing that for us today. And with that, we've come to a close of this event. We will be sharing the recording of this event very, very soon on social media. So keep following us on social media, and also keep following us on social media for more such events. So thank you, everyone, and have a very, very good evening.
Thank you. Thank you, everyone.
Thank you.
Thank you so much. Thanks, everyone. Bye.
Bye.